Mesdames et messieurs, ladies and gentlemen, le président du premier congrès international sur les soins de santé personnalisés, Chair of the First Congress of Personalized Healthcare, Dr. Pavel Hamet.
Merci d'être là. Thank you very much for still being here. I'm the only obstacle now between the sunshine in Montreal and and the Congress. I'm actually happy that you were here. I'm very happy about the crowd of the speakers we were able to have, and also I'm happy with the organizers, because we have so many actually trying things, new things, and I'm satisfied with the final results. I hope that you are too. We will see. So what we have tried to do is to show the broad scope of the need, questions and reflections in order to put the personalized or precision medicine into the healthcare. That was our objective. And that's what's first about this Congress, to not only personalize medicine, not only personalize the precision medicine, but how to get it to the general practice. If it stays only at the level of the university hospitals, it will never change the healthcare system. And we want to contribute to the healthcare system by bringing it to that level. So this is why we have all these subjects and try to have speakers, knowledgeable speakers, and then to those speakers to add the submitted abstract to it. So that was the structure of the Congress. Preliminary results, you were over 500 together with all the activities around it from 13 countries, 120 organized brain dates. There were other brain dates, spontaneous brain dates, but those 120 were organized. I'm very happy about it. And there was a public forum. It was in French, so not everybody in this room attended, but it was had by a well-known anchor from the television, and it was well done, and we have a nice contact with the public. This is one of the important things. Public have to know about it. Public have to be the tool, target, how to bring it to the attention to the health system and politics. I really would like to express my greatest merci, tribute our organizers and all our partners and members of the committees. You have seen this sentence several times during the meeting. Hippocrates was actually the guy who first time said something about personalized medicine. It's more important who has the disease than which disease he has. And I'm adding to it that what we have after that is important, because in order to go to the future, to go to something new, we have to see how medicine evolved before. We have observational medicine. It was very important. Avicenna's first textbook by a Muslim person and stayed for 4 centuries. The main textbook. Claude Bernard to Osler in Montreal. I was very happy that how Osler was celebrated by several speakers. And then we have evidence-based medicine. And evidence-based medicine actually also comes from Canada, basically, because it came from McMaster by David Sackett, who established the grounds of what is the evidence-based medicine, what kind of evidence, what is the level of evidence, and how it should be gathered. It brings a lot of discipline in the gathering new knowledge, but at the same time, it was irrespective of the individual. And we are still stuck with this in many decisions of which drugs go to the market. If it works in 30,000 people, it's allowed for everybody. But then we are also stuck with the fact that if the half of the subjects don't respond to the drug, the consequences for the health system are what they are at the present time. And then came the medicine based on the person, from Mendel to Archibald Garrod, Watson and Crick, and then to receptineomics. Actually, the first kind of real personalized medicine based on the drug is from Archibald Garrod. You know, Archibald is the guy who invented the one enzyme, one disease, one defect, one gene. And he described actually in personalized medicine, in pharmacogenetics, the predisposition to the drugs, which is on individually based. And then 100 years later, Herceptin. Initial failure. We have to learn from that. We have to remember that Herceptin was initial failure. Drug failed in large clinical trial, was withdrawn from the market. And then finally it was found out it works in some women. Why? Because there is a different expression of a gene on the surface. And that is the start of the companion drugs and so on, one of the most important component of the personalized medicine at present time. And then all kind of coalitions, and we were glad that we have a president of the coalition here. Definitions of personalized or precision medicines are many, but what I think is needed in any definition is exemplified in this one, environment. It's not only genes, it's not only omics, it's also environment, personal decision, and so on. That components have to be remembered for the future. What we have to remember is that what is the current situation? In current situation, medical healthcare is close to the wall. We will hit the wall soon. When it goes to the half of the national budget, it cannot continue. So we have to realize that this is the environment in which we are living. So how we are going to introduce sometimes expensive components have to be think in that context, and we have to prioritize in the development of personalized healthcare. We have to put a priority to the things which help also to decrease the expenses for the countries. Because if you look at it, that's the curve of the expenses, and this component are drugs. And this is mainly due to the biologics. So biologics are useful, targeted, and horribly expensive. So we have to rethink how to use it. At least it has to be used only in the subjects in whom it have at least side effects and it's effective. So at least to that, and in that personalized medicine can be of tremendous help. Technically, it's no problem. We have the technology which can do it, and all the statistics behind it, it's being developed, and this is not a problem. Problem is that in the last 2-3 years, all the genetics, all the GWASs put actually not at the best light to our field, because the contribution to the revolution didn't happen yet. Most of the diseases were tested. Most of the diseases were initially failure. In my field of hypertension, there was nothing in the first test. But then you look at it, how it was done. GWAS was done on hypertension when hypertension was detected by questionnaire. It was not even measured. So we have to do something more about but the use of those GWAS is going to be extremely efficient, and new pathways and new knowledge. But at present time, it costs this, each dot is the GWAS, and each dot cost $10 million or so. So all diseases are now done, or most of the diseases are done, but then we have to do a kind of next thinking about it, how we are going to use it. What are the reasons for the very small contribution? Heterogeneity, which was not looked. There is usually no respect to the treatment. In some areas, if people are treated or untreated, you miss the signal and so on. There is a lack of attention to geoethnicity. Genes versus environment is a very important component. We always speak about it, but we don't put it in the action. We don't really calculate, we don't really evaluate impact of the environment, of the importance of the genes throughout the life, and so on. We also learned over the last few years that certainly in complex diseases, it's not going to be one gene, it's not going to be 3 genes, it's going to be a set of genes in order to distinguish the affected from non-affected, in order to have a this is translated usually to the genetic risk score, and I will give a couple of examples out of it. Omics exist. I calculated the cost of this paper, and it's unbelievably expensive. That was done on one subject, Michael Snyder. On Michael Snyder, all omics available were done over 2 years. Only once, the total genome sequence, a total genome sequence of his parents, but then everything else was done periodically. Transcriptomic, immunomics, and all that was done periodically. 2 episodes of flu. During those episodes of flu, the immune genes went up before the symptoms. After the second episode of flu, he became diabetic. He had 29 genes of coronary heart disease from his parents and 30 or so genes from type 2 diabetes. He didn't have the disease. After second environmental episode, second stress on the immune system, he became diabetic. But he didn't just take drugs. He changed the suit, get the sweatsuit, start jogging, and lost the diabetes. How temporary, for how long, doesn't matter, but you can still act. This example is that you can still act even on something which sounds definitive. You have 29 genes of diabetes, you will get it. This is one of the major problems, how we are going to handle that. We know that most of the drugs of complex common diseases work in half of the subjects. We know that. We also know that most of the drugs have side effects, complex side effects. We are not organized to put that knowledge in action. And this is one of the major goals, I think, in personalized medicine. How we are going to help the government health system to get the drug only to those in whom it can work. At present time, it's given to 100% on the slide. 50% as a mean will work. 50% still may have side effects. I certainly pay for the drug. We, as physicians, we give one drug, and if it doesn't work, we add second drug and third drug and fourth drug. 3.2 drugs for any hypertensive, another 3.2 drugs for the diabetics, 2 drugs for the dyslipidemics. So people end up with 7 drugs by definition at the age of 60. Half of them don't work. We cannot just remove them, because if you are removing the drug, you have to bring the patient for blood pressure next week. It's a lost day and so on. So we leave those drugs. This is half of the cost of medication in the country. So we have to do something about it, organize the health system to go through it in the rationalized way. So the right person, yes, we know how to do it, but we are not ready, we are not organized to implement it. Right test is one of the problems, and the most problematic is the right interpretation. We don't have the system in which physician cannot interpret. Even if you give the physician the complex results of the genomics of his patient, he cannot interpret that. So there is a lack, and this is part of what we have to develop in the system. So we have to bring the data together, clinical, familial, geoethnic, and genomic data, develop decision support tools, build a comprehensive, useful, and friendly user clinical workflow, tracking patients' outcome, and understanding the cost shift of our health system. All that have to be done at the same time in next forthcoming years if we want to put personalized medicine into action. One component of the regulatory system, it's really doing an admirable job, I think. The FDA went through the initial Herceptin approval through a very systematic way, how to actually try to facilitate the implementation of the personalized medicine. I think that was well summarized during the Congress. But there are additional problems do we have the competence? Do we have the knowledge? Do the physicians have knowledge? There is no teaching of personalized precision medicine in our school here. There are about 5 schools in the United States which have courses really devoted to this. It needs to be changed. Offer to risk stratified prevention, risk assessment, delivery of personalized intervention, how to do it. So those competencies have to be translated to the healthcare providers. Teams in the present primary care genetics needs the knowledge of the genetics. Physicians know about Mendel. They know that Drosophila has genes, but the knowledge is monogenetic. Knowledge is not on the complex genetics. Knowledge is not on the most diseases having a genetic components. So that this needs to be translated. Identify individuals, how to do it, how to assess family history. This is frequently mentioned in criticizing personalized medicine. Oh, I just have to take the history, it's better than the genome scan. I just ask the history of history. Family history is very powerful in identifying families at risk. Family history doesn't tell you which of the 2 brothers or sisters will have inherited the gene. This is why this is the new precision. This is that change from the medicine before. People say, we always did personalized medicine. Yes, but at the level not precise, family level. In that family, you have to survey the cancer. Yes, but who will be subjects for this surveillance? With Barta Knopper's input and Jan Joly and their colleagues, we have developed in our group at least the strategy how to handle the path from the taking the consent, recruiting, then to denominizing the electronic health record, and then to putting all the knowledge from clinical components and genetic components together. But at the end, there is still a component which is not completely solved. There are 2 components. One is what about the rest of the family? Can you, once you have something identified in an individual, how you go to the rest of the family? Do you have to have informed consent to do it? How do you handle that information? Because if I'm in genetic clinic, the patient in front of me is there sitting with all his ancestors and all his descendants. And I'm supposed to inform them. Can I force the information? Can I somehow oblige them to transmit it in the whole family? This is not all solved on that legal component, but there is another component. At present time, from service I'm leading at the SHUM, we are giving physicians who ask for a test 7 pages of report. This is usually done to an oncologist or somebody who at least know about it. He knows what he should read and what he shouldn't read or may omit. The findings of unknown significance, should we give it to the GP? He has 6 minutes for patient. We are going him 15 things to rethink that SNP is of unknown significance. This is not feasible. It should not be done. We have to somehow translate it to a recommendation. Simple recommendation, 6 lines, like radiologists do. Radiologists don't give you the pixels of the CT scan. They give you 4 lines what they see in a picture. So we have to translate it to a picture, and that picture to translate to the physician in the clinically actionable way. And then there is a blue line below it, and you click on the blue line, you get the 7 pages if you want. But they have to be somehow to translate it to the physician, otherwise it will not take into the practice. And then what we do, what we have decided that the easiest way at present time is to stratification. Stratification of group of the patients, or the high risk and low risk, And then the high-risk subjects, should they be treated one way or another way? This is probably the closest, in my mind, this is the lowest hanging fruit for personalized medicine, because this is at present time feasible. There are a couple examples of it in the literature. One of them was presented by Nora a couple of days ago here, and this is how to stratify the subjects to do a screening, on which patients you are doing the screening. If you do it on the high genetic risk subjects, then you decrease the unnecessary, there's a potential for decreasing unnecessary surgery for the prostate cancer from 50% to 2% in high risk. So this is something, this single example for me would be very, very telling to the ministries of health, to decrease the unnecessary surgery from 50% prevalence to 2%. There is another one, this is genetic risk of levels of cholesterol and how it translates to the efficacy of the statins. In the three largest trials that was done, and it's clear that if you give statin to everybody, then you are wasting most of the money. About 30% of the subjects are at high risk. And those subjects respond by prevention. Only the high risk respond. The low risk don't. So this, again, and this is a couple $2 billion a year worldwide. So this high risk stratification is going to be probably one of the pathways how to persuade the public health system to incorporate personalized medicine. And what we have to do, which is imagine here, is that identification of the subjects at the risk decrease the risk. Just to be identified gives a potential for prevention, gives a potential for treatment. And we have to get used to it, provide the data, how much benefit is there once you identify somebody at the risk for the BRCA2, BRCA1, how much benefits is there, how much you decrease the risk. That have to be captured, that have to be calculated. We have to be responsible to the public. If we are paying for the test, what is the outcome in money gain by decreasing the risk? In our own research, this is an example from the diabetics, largest study in diabetes, advanced, and at the low risk, that study was aimed at the intensive treatment of blood glucose and intensive treatment of blood pressure. At the low risk subjects, there was no benefit. This is 2/3 of the subjects. In 1/3, at high genetic risk, this is genetic risk score of 17 genes. At the high risk of genetic risk score, there was a 52% benefit in decreasing mortality. So again, yes, the people have to be treated, but if we treat all, there is no evidence for the benefit. If we treat people who are at high risk, we may have a huge benefit. They'd have to be evaluated first and then tested for the outcomes. So missing heritability is something which is still widely published. There is a missing heritability. I'm not sure it's a missing heritability, it's just missing point. We have to proceed and recognize where the genetic is useful, where the genetic should be applied, at high-risk subjects, at what age. I'm saying to my students, at the age of 75, somebody who has 2 infarcts, he is diabetic, hyperlipidemic, I don't need to do his genetic risk score. But in somebody who is 30 and has a family with high risk, maybe that person will, and if I need the risk score of his father, that's a different story. But it's not for his father, it's for the next generation. The reason why we want to do that, yes, we will increase the cost to the public health system at the initial screening, at an initial testing, but that cost should be compensated by the number of the years, and we can prolong the capacity of contribution to the society, and we shorten the length of the end-stage disease. So, and we have to calculate that for every component, for every intervention, for every test. And this is, in my view, this socioeconomic impact in action. So what we need to do is recognize the role of interdisciplinarity in personalized healthcare. It was well summarized in this Congress that the players are patients and their families. There's an active role for a patient, how they help us to design trials, how they help us in recording their own data and participating in studies. Then naturally geneticists, genetic counselors, medical specialists, family practitioners, pharmacists, and nursing practitioners. Now they are essential collaborators. Informatics is one of the most essential collaboration we need, but we also need electronic record providers and health economics. And then there are support collaborators. Very important are general scientists and practitioners. Partners, bio, pharmaceutical industry, insurance companies. We should not consider insurance companies as enemies. We have to make an alliance with them, which is not easy. The supporters, public and private healthcare organizations, public health specialists, health regulators, and legislators. Environment should not be only academic environment. It should be first-line medicine. And finally, the educators. And educators should be the public, physician, healthcare practitioners, and media. We need education at all levels of the society. But there are still going to be barriers. We need to submit any finding, any discovery to prospective trials. But it probably should not be as RTC as we have been used to. It should be a novel, there's a need for novel adaptive design, as it was discussed during the meeting. Then we need the data access and electronic health records. This is still not completely in the work. And there is always going to be resistance to change by users, healthcare providers, and physicians. But I think that patients will help us. If we well explain to the public the potential benefits of what we are doing in personalized medicine, they will help us to persuade the rest of the society to do it. Unresolved ethical issues, and this is the slow path of medicine as art to the science. Just to mention, for many of you are Canadian, we are in possibility soon that we will have a great news for Canadians in that the bill S-201, which passed through the Senate, as introduced by James Cowan, was approved by all provinces, is now at the Parliament level. And Parliament will discuss it and hopefully vote for it. We have a support from many organizations. We have a support actually even from the United States. And we need the support from you, from all members of the Parliament to vote for it. Fear of repercussion should not prevent our society from realizing the potential of the genomics. The people are depriving themselves from prevention by not being diagnosed because they are afraid that it will have consequences in their life. That should be stopped. And it's always going to be, yes, genes, but also individual choices and environment. If I would have a thought for if we would go further from this meeting, the next step, probably a little bit more about environment and individual choices, and perhaps a little bit more of young persons being invited, young forum or some component for the next generation of people involved in practicing personalized medicine. And I thank you for being here. I hope that you enjoy the Congress, and now I hope that you will enjoy the afternoon in Montreal. Thank you very much.